How is it not working?
Hi, everyone.
Hi, how are you
We were a
doing?
minute late. We're waiting. Our main guest is having technical challenges getting into the webinar. So I'm just working with him. Hopefully, one more minute, but I will introduce the session.
Yeah, virtual, meetings are not without technical difficulties. It keeps it real. But we are totally happy that you're joining us today. Um, there's we rely so much on our medical oncologists. They're really the driving force between making these clinical trials and research successful, and also being kind of, the gatekeeper for patients such as yourself, helping guide you in the direction of your best treatment options.
Yes, and the for today, I know some of you have been to webinars before, but for those who haven't, we do record it and put it on our website, and we can follow up one-on-one with you as well for any questions. We do have a live Q&A feature, so you'll see the Q&A button. You can ask anonymously or just post and it'll have your name. Um, and for today's panel, we have Cheryl, our survivor and chief patient advocate with 1104 Health. And there he is.
There you are,
You're
Kosh!
right in
Hi,
Yay!
how are you? Sorry, I don't know what was taking a little while. Thanks for your patience.
No,
Oh, that's all right.
no worries.
Technology sucks when it doesn't work, man.
Yeah.
Yes. Uh, and then Dr. Farazvi, medical oncologist with Maryland Oncology Hematology. He founded his current practice after holding numerous positions in his career, which all started at Georgetown for his residency and fellowship. So I'll kick it off to Cheryl to talk through our topics with Kosh.
Great. Yeah, and I just left your cohorts at Georgetown for the patient symposia. So
Oh,
I was thinking I wasn't going to get hop on here in time. But so thank you for joining us today. I'd like to kind of, kick off. I mentioned, how, our local oncologists and are really the driving force between making clinical research successful and getting the patients, in the right direction for their cancer treatment. And I wanted to know if you could take a few minutes to kind of tell us a little bit about yourself and why did you decide to go into medical oncology?
sure. It's a pleasure to be here. Thank you all for inviting me, and thank you for giving me the chance to talk about this. This is really important to talk about how we understand clinical trials and how I got into the field of oncology. Just a background: I'm a medical oncologist. I work with a group called Maryland Oncology Hematology. We have about 50 medical oncologists in our group, about another 7 or so surgeons and some radiation oncologists, so about 60 something physicians. I went into oncology never thinking that I was going to do this. Some people grow up and they know I love cancer. I really want to do this, and I kind of stumbled upon it. I actually thought I was going to be a primary care doctor, just like my dad. I loved the patient-physician relationships that you develop as a primary care doctor. But I also loved ICU medicine, where you get to sort of deal with life and death situations. And so, problem with life with ICU is that you don't really have any patient relationships. And the problem with primary care is you don't always have life and death situations. And so I tried to find a career that would blend the two of those. And I stumbled upon it because of one patient who I had the fortunate pleasure of sort of working with from the time they came into the hospital with some shortness of breath to the time they were diagnosed with a pleural effusion, which turned out to be cancer. I had to help them understand that, help them understand the treatment options, and help them go through the entire sort of acceptance phase and treatment decision phase as a medical student. And that's really what opened my eyes to the field of oncology. And since then, I've been practicing that for about 20 years, and I love it.
That's great. And I bet coming from your background, it also enabled you to have a little more compassion and empathy for the patient. I think a lot of times oncologists are pretty cut and dry and don't really, take time to kind of listen to the patients. And I applaud you on that. I know in our on our call today, we have a lot of newly diagnosed patients that have joined us today, and I wanted to kind of use this time a little bit to talk about why would a clinical trial be considered for a treatment option. And when you're talking about clinical research and clinical trials, it makes some people really nervous because they think, I don't want to be a lab rat, but it's not that way. And there are safety protocols in place. And in most cases, you're experimenting with maybe a combination of therapies of approved drugs. So there's an understanding of what's going to be expected. But can you kind of take us through that process of you've got your newly diagnosed patient and you're determining treatment and why maybe you would go the direction of a clinical trial?
Sure. So by way of background, I'll just give a little bit of history as well. When I did my fellowship, I did an extra year in something called developmental therapeutics at Georgetown, where we spend time really focusing on novel therapies and first in human studies, which we call phase 1 studies, where we may have developed some experience in animal patient population, but where we're really looking at sort of dose limiting toxicity as our main driver for the basis of that phase of studies. What we do then is we find out that some of these patients who are in phase 1 studies have some real great responses in certain disease types. And we take those patients from the phase 1 where we identify the dose limiting toxicity, and we then elevate it to another phase where we look at sort of disease specific opportunities for patients to benefit. And then it goes down the path. And so when you think about clinical trials for patients, there's really a lot of reasons for it. I think at the macro level, as a physician, as an oncologist who spends a lot of time studying the pathophysiology of disease and understanding how that pathophysiology translates to clinical outcomes, there's a true fascination and appreciation for the importance of scientific, rigorous clinical trials in the form of double-blind and placebo-controlled studies that really elevate and improve science. So we have that in our DNA, no pun intended. But the other piece about this is that nowadays oncology is moving so fast that we're really discovering mutations and targets and drugs before we have. I mean, it's coming at us at such a pace, and there's such a direct correlation between therapies and mutations, and the potential opportunity to have improvement in outcomes, that the only way we're able to sort of bring those treatments to patients is through the conduit of clinical trials. Without clinical trials, we're basically rendering an entire arm of treatments, which are in many cases life-changing, unavailable to patients, because these drugs are coming out at such rapid paces, and because we understand the pathophysiology of the disease in a way that we never understood before. Before, we used to treat 100 women to benefit 4. And now what we're doing is we're testing 100 women, identifying the mutations of every single one of them, and then coming up with therapies specific for that particular mutation for that particular patient. And to do that, unfortunately, the only way we can do that effectively is through clinical trials. So when I think about clinical trials, when I'm making decisions about who to put on clinical trials, first and foremost at a macro level, I want to elevate, I want to promote clinical trials for the purpose of my field. So that's just there in us as physicians. But more importantly, we know that for our patients who are in front of us, who are dealing with a life-threatening condition, that we want to provide them the best care possible. And so in some cases, the best care possible is standard of care. But in some cases, the standard of care is just not good enough. And if we know that a patient harbors a mutation where there's a drug that works dramatically for that patient, not providing that in the form of a clinical trial is oftentimes rendering or offering inadequate care. And so for us, clinical trials, having them available for patients and being able to screen patients to make sure that those who are appropriate for a clinical trial are getting access to clinical trials is incredibly important for their overall care. So there's a lot of factors that you sort of think about when you're trying to screen a patient for a clinical trial, and so we're not really putting patients as guinea pigs. I want to be careful to make sure that people don't think that. These drugs that are coming out to patients have gone through a lot of different studies already. In many cases. And so because of that, there's a lot of experience and there's a lot of science behind why we're doing this. And so we really think carefully before we put patients on studies, and we identify studies that really only make sense for the patient based upon their disease and based upon their options. Like I remember, just to give an example on the counter side of this, I was on a plane. I was a fellow one time. I was on the plane, and I was sitting next to me. There was a gentleman typing on his computer, and he was putting some slides together around some oncology slides. And I said, "Oh, who's this?" So I said, "Oh, hello, sir. I'm an oncology fellow. Who are you? I see you're putting a presentation together on oncology." He says, Dr. Einhorn. Dr. Einhorn is a famous oncologist in Indiana who basically cured testicular cancer. And so I said, "Oh, Dr. Einhorn, this is great. So tell me what's new, and what are there any new clinical trials that you're doing?" And he said, "And is there anything new in testicular cancer?" And he goes, "It's hard to do better than cure." And so I said, "Oh, okay, well," but that came about because he did all the clinical trials to get us to that point. So yes, clinical trials are great. Sometimes it's appropriate, sometimes it's not. And what we have to do is when we bring clinical trials to our patients, we have to understand when is it bringing the care to a higher level and when is it not. And so there's a lot of work that goes behind the scenes to make sure that the appropriate study for the appropriate patient at the appropriate time is available.
Yeah,
And can
very
you
well said. I was thinking, I'd heard today that, probably like 10 years ago, the goal was for to manage cancer. And that's where they were going through with the clinical trials. And now, because we know so much more about these drugs, it is now to cure cancer. And I think that it is remarkable the change in all different types of cancers that we've seen happen in this current landscape. And it's by clinical trials like the one I think ESMO is a conference that's going on right now, and they were talking about looking at this 10-year study between I guess was it shoot at Nivo and ipilimumab, and looking at that success rate, which when combining those two drugs was done on a clinical trial, while both of those treatment options were actually approved by the FDA on their own, but then they came together in a trial and they've changed the landscape in durable treatment options.
Yeah, I mean, every single treatment that we provide today came to us through clinical trials.
Yeah.
And so there is no treatment that we're giving to patients today that didn't at one point come to us from a clinical trial. And so these clinical trials, if we're comfortable with status quo, then there's really no role for clinical trials.
Right.
But if we as a community of scientists and physicians and patient advocates are not comfortable with status quo, then it's incumbent upon us to be trying to make things better. And the best way to make things better is through the format of clinical trials, where we're not putting patients, again, we're not putting patients in a guinea pig scenario. We're giving them either standard of care or standard of care plus something to make it perhaps better.
And asking a question here related to what some of the registrants posed when they were signing up, because most are newly diagnosed patients or caregivers, we just heard that clinical trials oftentimes might just be the best treatment for you, and you're getting early access to them. But what kinds of things should you be asking your doctor in those early days to figure out if it's right for you? Obviously, this is something you do proactively, but in many cases, we want to arm patients to know, what to ask in those meetings.
I think it's important to understand, I tell my students, spend the time, the first time you see a patient, really educating patients around their disease and their treatment. And not just their treatment in terms of side effects and dosing schedules and so on, but why we're here, why we're doing what we're doing, why we're giving the regimen we're giving. And when you do that, when you spend that time educating patients on the why, not just the how and the what, but the why, then you start to, it actually exposes the opportunities. Because when you start to explain the why of why we're doing this and how we got to this point and why this regimen we're giving you is the standard of care, but how this became the standard of care because it beat the previous standard of care when we added drug X to regimen Y, suddenly people say, okay, well, that's great. And sometimes I'll hear a patient say to me, well, what if we did this? and I can see the light bulb going off in their mind as well. And I'll say, well, funny you should ask. Well, interestingly enough, that very question is being asked today by a lot of investigators all over the country. And that's why we have a study today doing the exact thing you just asked, which is, can we make it better by virtue of adding a drug, to this cocktail of that is currently the standard of care. And so I think that discussion around the why is really important. It takes time, and you have to really be able to sort of explain very complicated ideas sometimes to patients that may not have the background to understand that, but are still smart enough and are really dedicated, obviously, personally dedicated to understanding what they need to do to take their care in their hands with their physician and to provide themselves the best chance of a cure. So I think that is really important, and it helps open up the door to more of a receptivity from a patient around clinical trials, because they understand why we're doing what we're doing and why we're trying to improve the standard of care, and to make things better.
I wonder if you're in a situation where you're a newly diagnosed patient, maybe a newly diagnosed late stage patient, and your oncologist just kind of throws you into standard treatment of care, and or if that's what they're offering you, and you don't feel that that might be the best resource. What are your, how do you go about navigating if the clinical trial might be a better option for you than what your local oncologist might be giving you?
Sure.
Um,
So yeah, so I think it's always important to just ask your physician directly and say, are there clinical trial options available for me that might be better for me than current standard of care? I mean, I think just asking that is always really important. Sometimes the physician may say yes, may say no, may have access to something, may not have access to something, but also may realize by you asking the question that you are interested in trying to pursue something beyond standard of care. Sometimes there's sort of misalignment in expectations between the physician and the patient around what one's looking for. And so by opening the door, by asking that directly to the physician, you're basically letting the physician know that I really want to be, I'm open and willing to look at clinical trials as a part of my treatment plan. So once that happens, if the physician says, yes, there is, but here are the ones that I have available, and they're not really good studies for you, then you can ask, well, what about outside of here? And I think that's where you look at other options. Hopefully your physician, I always tell my patients, look, I'm here to be your advocate. I'm here to look for you. I'm happy to look for you. I'm happy to do some searches for you. But I think, finding that path for you to identify and find clinical trials in a way that you can understand is incredibly important. So, there are websites like PubMed and clinicaltrials.gov and other sites, but that are available, but they're not really easy to understand. And oftentimes you print something and it gives you all this information, but it doesn't really give you it in a clear way.
mhm.
And so I think websites or avenues where you can understand the clinical trials in a way that you can digest, and where you can sort of take things into your own hand a little bit with your physician, and not in a reckless way, is incredibly important.
Yeah,
And
that's where we kind of have come up with this tool at 1104 Health. Is you can enter in, your biomarkers, pre-existing information, demographics, not only on your disease, but where you live. And it'll give you some options for second opinions. Because being out there, today I was at a patient symposium. I heard again stories of patients that started out at a center that their doctor was not comfortable handing them off to somebody else or letting them do research or letting them have the opportunity to get treated somewhere else but their center. And when those things happen, that's the time when you actually have to take your cancer into your own hands and advocate for yourself if you don't have an oncologist like yourself. And unfortunately, we're trying to have tools out there to connect you with good doctors that can give you a nice overview. But do you also find that within your synergy of oncologists that they don't feel comfortable moving people outside of their center?
I still believe and I still hope that, physicians, we all want what's best for our patient. There's, there's no, you know, from a selfish standpoint, there's no shortage of patients, unfortunately, So, if we can provide care that we feel is the best available care for a patient who's going through a fight for their life, then I definitely always want to provide that. If we feel like we can't, that there's something better available elsewhere, then we can actually grease the wheels and make things happen a lot faster. So it's that's really useful. But that being said, you know, sometimes there's just, I do think that patients being their own, advocate to sort of find paths that might be available to them is incredibly important. But in order for you to do this, in order for you to do it well, you have to really be able to do it with some trusted support to be able to decipher what's good from what's bad. Because unfortunately, sometimes, often, there's another extreme, which is patients may say, I'm not getting good care unless I'm on a clinical trial. And that can also be wrong too. And so I think, having an ability to sort of decipher and filter what's good from bad in terms of clinical trial options is incredibly important. And having a trusted person or program or organization that can do that and help you with that is really important. Because honestly, like, patients don't always know what's the right study for them, or whether or not this study is going to be, sometimes none of us know, but there might be some studies
Right.
that are just not right for them. So you really need somebody to help guide that. And I think, usually there's time to get to they're saying in surgery, think twice, cut once. So there's usually time to be able to make sure that you're making the right decision. Not
Right.
always, but usually.
Yeah, because a lot of these drugs are based on your particular pathology, the mutation of the type of cancer that you have. What are those drivers that are going to make that treatment actually effective or not effective? And sometimes, unfortunately, the patients fall under that area where their mutation does not have an effective treatment strategy yet, which is very discouraging as well, right?
And
Absolutely. Yeah.
for any of the
Sorry.
patients participating here, if you have any questions you want to ask directly, definitely put them in the chat. If you want to follow up separately with us about anything we mentioned or getting our help with, who you could see in your situation, you can email us afterwards. I'll email you from our navigator at 1104 Health email.
Yeah, this application is such that I can't see who's out there. So I to all those patients out there, nice to see you. I wish I could see you, but hopefully we're answering some of your questions.
Yeah, I definitely think we did. The biggest things I hear, it's a lot of uncertainty, even understanding their diagnosis, which I think you've covered there. Like, you have to really understand everything first before you can even be a part of having the discussion. And then just being an advocate and asking those questions about clinical trials or what's available. You aren't going to know the answer, but you can at least ask the questions.
Right. Absolutely. I think that's sometimes we're afraid to ask the questions. Sometimes we're scared, and we don't want to upset or offend a physician who we're putting our own lives in their hand. And the fear of asking the question can sometimes close doors for us. And I think I just want you to know that physicians are not going to be offended if you ask the question. Um, Please know that we appreciate it. In fact, I like it because it makes me realize that this person is going to be a partner with me on this path, which makes it that much easier and that much better of an experience for both of us. So don't be afraid to ask.
Awesome. Well, thank you, Cheryl and Dr. Thrasby, for joining us. To everyone on the line here, you'll get the recording and we'll also have it on our website if you want to reference it again. But yes, thank you everyone for your time today.
Yeah, we really appreciate it. And thank you, Dr.
Thank you.
Tosh. We totally appreciate your time and taking it out of your busy schedule to relay this really important information out to us.
No, thank you so much. I really appreciate it. It was great to connect with all of you, and appreciate all that our patients do, because you guys are going through a lot, and we're here to help.
You said it best. All right. Thank you. Bye, everyone.